tes suara tes.
Tinggi. Boleh start lagi? Boleh start lagi? 5 minit. Okay, dah. Okay, dah. Okay. Bisa. Dah on.
Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phones are switched into silent mode. Thank you. Before we start our CME, here are some important announcements to highlight. For attendance, kindly scan the QR code on the screen, which will be displayed before and after CME session, or use the attendance link provided in the live chat of our YouTube channel. For those who joined the CME via online, any questions are welcome through the chat box in YouTube channel. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to our honorable guest, Yang Berbahagia Datuk Dr. Abdul Haris bin Muhammad, HRPZ2 Director, Dr. Putri Nurbaya binti Muhammad Ismail, Deputy Hospital Director 1, Dr. Tengku Anas Fathi bin Tengku Ahmad, Deputy Hospital Director 2, Dr. Nurhana binti Muhammad Fazil, Deputy Hospital Director 3, Wan Norma binti Yaakob, Deputy Director of Management, Head of Departments, Specialists, Medical Officers, Nurses, and the rest of HRPZ2 staff. First and foremost, I would like to thank everyone for allocating your time attending our CME today. I am Dr. Aini from Ophthalmology Department, will be your MC today. Without further ado, I would like to invite Mr. Ahmad Munir bin Hashim, orthopedic surgeon, to present today's CME with the topic Malignant peripheral nerve sheath tumor. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. So I am Dr. Ahmad Munir bin Hashim from Orthopedic Oncology Unit HRPZ2. Today, this morning, I will be sharing in our CME. Actually, I will change the topic a bit. I'm still talking about the malignant peripheral nerve sheath tumor, but we changed the title a bit, becoming is there something called infected neurofibromatosis. Actually, this is a sharing of our recent experience in managing patients with neurofibromatosis presented with malignant transformation, which was early diagnosed as infected neurofibromatosis. So I'll be talking about a little bit about the neurofibromatosis. So this is outline of my presentation. We're talking about neurofibromatosis, and then what is its malignant transformation, known as malignant peripheral nerve sheath tumor, or MPNST, how to diagnose it and the treatment of it. And then subsequently, my Dr. Amir will present the cases that we had recently. I mean, this year, there are 3 cases that we recently encountered. So what is neurofibromatosis? It's actually a disease which is an autosomal dominant disease, first described in 1882. So it's quite some time already, by a German pathologist known as Friedrich Daniel von Recklinghausen. So it is one of the most common genetic disorder present. Initially, people only know that there is one type of neurofibromatosis. Only 100 years after the disease was described by this German pathologist, people realized that there is actually 2 types of neurofibromatosis, which is neurofibromatosis type 1, or commonly known as a peripheral neurofibromatosis, and neurofibromatosis type 2, which is known as central neurofibromatosis. So our interest today is only neurofibromatosis type 1 because it is highly related with the malignant transformation. So what is neurofibromatosis type 1? Compared to the neurofibromatosis type 2, this is the more common one. It occurs in 1 in 3,000 of the population globally. So that's why we can, I think everybody have seen this type of patient, neurofibromatosis type 1, because their presentation is so obvious. What is their presentation? The first symptoms that occur in this patient is the cutaneous manifestation. The cutaneous manifestation is the cafe au lait, I mean the brownish spot that present over the skin. Almost every patient of neurofibromatosis have cafe au lait manifestation. Secondly, the neurofibroma. They have the small benign tumor called neurofibroma, which occur in the peripheral nerve. Usually the neurofibroma doesn't have any symptom. However, they can present with some minor symptom of pain, something like that, discomfort. Some of the neurofibromatosis patient will have a big neurofibroma, which is known as the plexiform neurofibroma. It's very obvious. It's very discomfort to the patient. It causes discomfort to the patient. Very bad cosmetic features. So this is the criteria to diagnose neurofibromatosis type 1. So generally, how do we diagnose? Using this criteria. Patient, what are the criteria of diagnosing neurofibromatosis type 1? Presence of either 2 or more of the criteria mentioned showed in this diagram is a diagnostic of neurofibromatosis. So we don't need to do a genetic study or anything. So as patient have 2 or more of the criteria, he is or she is a neurofibromatosis patient. What is it? Number 1 is presence of the optic glioma. This one need a ophthalmologist to diagnose. Number 2, present 2 or more leaf nodule also in the eye. Number 3, this one we can see from the skin, the freckling of the axilla or the groin. Number 3 is the presence of the cafe au lait, but it needs to be 6 and above. And then the size in pre-pubertal age, it should be at least 5 millimeter, and then post-pubertal age, it should be more than 15 millimeter. Anything smaller than that, because a lot of people will have something looks like this cafe au lait lesion. However, we only have sometimes 1 or 2, and the size is small. It doesn't fulfill the criteria. So don't worry if you have some small cafe au lait lesion in your body, on your body. And then number 3, presence of 2, the neurofibroma, the presence of 2 or more of neurofibroma, or a single plexiform neurofibroma. Single big neurofibroma, 1 is enough to diagnose. And then the other one is the distinctive osseous lesion, such as congenital pseudoarthrosis of the long bone. Okay, we on orthopedic do see, we know that congenital pseudoarthrosis with all these criteria, this presence of 2 or more of the criteria is a diagnostic of neurofibromatosis type 1. This is one of the example of patient. This is my patient in Penang General Hospital. This is one example of the plexiform neurofibroma. So in this patient, we can see the small neurofibroma as well. Oh, tak boleh tunjuk. We can see the small neurofibroma, and as well as the cafe au lait spot dekat kaki left lower limb there. Next is the malignant transformation of the disease. So what is the relationship, the association of the neurofibromatosis type 1 and the malignant transformation? So if we see in the data, the lifetime risk of a patient of neurofibromatosis transforming into malignant transformation is about 8 to 13%. However, if we see the malignant peripheral nerve sheath tumor itself, 50% of the patient of malignant peripheral nerve sheath tumor, PNST, is neurofibromatosis type 1. Although it's a rare disease, but in a patient who is neurofibromatosis, they have a higher risk of developing MPNST, because MPNST also come from sporadically or either post radiation, doesn't related to the neurofibromatosis. And then the plexiform neurofibroma itself has a 10% risk of becoming malignant. So this malignant transformation has a very complex underlying pathogenesis of the genetic mutations. There are many genetic mutations involved in the malignant transformation of the neurofibromatosis. So what are the clinical presentation? Pause sekejap. So how do we suspect patient having a malignant transformation? Generally, in any soft tissue sarcoma, any mass more than 5 centimeter representation, deeply located, deep to the fascia, rapidly enlarging mass, and start causing symptoms such as pain, is a sign of a malignant transformation. So in neurofibromatosis itself, the neurofibroma itself, if one specific symptom is the pain, new pain or worsening previous pain, or number 3 is the persistent pain in neurofibroma, is a sign of a malignant transformation as well. So when we encounter all these symptoms, we need to think of malignant transformation. So how do we diagnose malignant peripheral nerve sheath tumor? Actually, there is no one specific test or imaging or anything that can specifically point this is MPNST. Number one, of course, we go clinically, followed by when we suspect this is a might be a malignant transformation. We do the imaging, necessary imaging, which may include the MRI as well as the PET-CT, and then we do a biopsy. Some develop a scoring system which combine clinical and imaging to achieve 100% sensitivity. However, this scoring or scoring system still not validated. So what does MRI tell us to suspect this is a MPNST? Number one is the low signal in T1 weighted image and high signal in T2 weighted image. This is all general criteria of a malignant transformation. It doesn't show that this is a MPNST. However, some people like Brodsky et al. Describe some criteria that has 100% specificity of MPNST. So the criteria mentioned by them is the perilesional edema, cystic degeneration or necrosis, and irregular margin in the image. And the meta-analysis show differentiation benign and malignant peripheral nerve sheath tumor with nearly 100% sensitivity using minimum apparent diffusion coefficient. These are all the sequence available in the MRI. Then the PET-CT. NCCN, which is the National Comprehensive Cancer Network in US. This one, NCCN, last year they recommend using of the PET-CT to diagnose MPNST because it has significance uptake of the marker. However, the diagnostic value is debatable. Generally, the SUV less than 2.5 is safe to be considered as benign, and SUV more than 3.5 is carry the high suspicious rate of a malignant transformation. But PET-CT scan in our country is not readily available everywhere. I think only 3 centers have a PET-CT. One in HKL, number 2 in IKN, 2 in Klang Valley, another one is in Penang. So it's not really, if we have it, we should use it. But if you don't, we don't have the luxury of having everything in our center. But this doesn't mean that we cannot diagnose MPNST. And then after imaging, confirm the diagnosis, we need a tissue diagnosis. We take a biopsy, send to the pathologist. Biopsy is generally done using a core needle biopsy. Some say, image guided will give you the best result because in some lesion, it's not clear-cut lesion. This is a malignant transformation. So if you do blinded core needle biopsy, we might miss the area of interest. But I think in our setting, the patient always present with a big tumor. I think no way we can miss the malignant part of the tumor. So Graham et al. Mentioned using image guided. This one this is the advantage of image guided. We want to differentiate between benign and malignant peripheral nerve sheath tumor. So the biopsy rarely cause any complications. Sometimes pain because we hit the nerve, because we do it blindly and then we hit the nerve. Or if the lesion is too big, the lesion can bleed, can pour out blood. It doesn't bleed like normal oozing of blood. It can pour out blood like water tap. So these are the examples of the immunohistochemistry markers available I'm not sure what is the standard of because it doesn't have a specific marker. One marker tell this is MPNST. No. So the diagnosis mentioned in some paper is exclusion by exclusion. They exclude this, not this, not this, and then they label it as MPNST. Only one marker you have 91% positive rate, which is the nestin. So treatment, what do we do with MPNST? The only curative treatment available is the wide surgical excision of the tumor itself, followed by radiotherapy to achieve good local control. So some mentioned that using a brachytherapy can achieve up to 88% good local control. Bear in mind, radiotherapy the only control local recurrence, but it doesn't affect overall survival rate. Again, brachytherapy is not readily available everywhere. I'm not sure about here, but in USM, in IPPT, they can do it. In unresectable disease and metastatic disease, chemotherapy is the choice. Even though the efficacy of the chemotherapy is very contradicting. Some say it does affect, some say it does not have any response. However, we don't have any other choice. A patient presented with metastatic disease, we don't have any choice except chemotherapy. The first line of choice is doxorubicin. So we need to evaluate the patient. We need to consider the toxicity of the chemotherapy and the effect that we want. So usually we refer to the oncologist, and then they will see whether they will give the chemotherapy to the patient or not. Next is targeted therapy. Do we have targeted therapy for MPNST at the moment? No. Because of there are a lot of underlying mutation of the genetic mutation of the MPNST. So people keep on going to do studies on targeted therapy on MPNST. So at the moment, these are the few studies. There are 7 or 8, all have no response. Only one left still, which is still ongoing. They are still enrolling patient using selumetinib or sirolimus, which targets certain receptor. So hopefully in the future, targeted therapy is the hope, is the hope. Not only for MPNST, actually for all other tumors, because of the evolving of the genetic study. Not to forget, especially for the primary care, counseling of the patients with neurofibromatosis is necessary. Need to alert them that they carry the risk of malignant transformation. They do carry, half of their child will have neurofibromatosis, and their child also carry the risk of malignant transformation. So we need to educate them the risk. We need to educate them what are the suspicious criteria, when to seek medical treatment, medical attention regarding their problem. Because early presentation might affect the overall survival rate of the patient. So talking about prognosis, generally MPNST have a poor prognosis because 50% of the patient presented with the metastatic disease. When patient present with metastatic disease, we don't have anything very effective to treat them. Moreover, MPNST with underlying neurofibromatosis carry worse prognosis compared to other type of MPNST. The MPNST without neurofibromatosis, they carry, with neurofibromatosis, carry worse prognosis. Overall survival rate about 50 to 60%. There are the most important factors determine the prognosis is the resectability of the tumor. So, is there something called infected neurofibromatosis? I searched in the internet, I only found this single case report published in 2010 by the Singapore group. They mentioned that they have a patient of plexiform neurofibromatosis over the groin region, presented with abscess. They did surgical debridement, sent tissue biopsy, come back as a benign plexiform neurofibroma, and subsequently treated with antibiotics, and the infection healed. Can't find any other publication or anywhere mentioning solitary infected neurofibroma. Infection of neurofibroma post-surgery, a lot. But infection in neurofibroma, almost, we can say almost zero lah kot. So next will be case presentation by Dr. Amir.
Assalamualaikum. My name is Wan Muhammad Amir bin Abdul Halim. I will present few case regarding malignant peripheral nerve tumor. We have counted few cases before. The first case is Madam N, is a 64 years old lady, underlying hypertension and neurofibromatosis type 1. She initially presented with swelling for the past 5 years. It was painless swelling and started to increase in size for the past 1 year. And the swelling started become ulcerated, and since she developed ulceration on the mass, she visit treatment at the KK, and she was treated as infected neurofibromatosis and uses a few course of antibiotics. However, the ulcer not improved, and then she presented again with bilateral lower leg pain and associated with back pain. And then she was referred to ortho. Upon review by orthopedic team, we was very shocked that time. We can see this huge mass on the back, and then neurology was there was a reduction in power from L3 and below. So our impression during that time was ulcerated malignant transformation of neurofibroma with metastatic to the lung and spine. She underwent wide excision biopsy on the posterior trunk and secondary suturing. Intra finding was ulcerated soft tissue tumor measuring about 15 cm times 20 cm at the posterior trunk with central hemorrhagic necrosis attached to the fascia, some part of the erector spinal muscle. This is intra-out findings. As you can see, there is a huge mass on the back of the patient with multiple Jeffrey outlet spots seen on the body. And this is a normal appearance of cutaneous neurofibroma, and this is abnormal. This is a mass with malignant transformation. And unfortunately, HPE came back with malignant peripheral nerve tumor, which is high grade. Second case is 50 years old Malay man, worked as a miner, underlying neurofibromatosis since childhood. He was not under any orthopedic follow-up before. He was referred by district hospital for infected neurofibromatosis. He presented with lower chest swelling for the past 2 years duration. The swelling increasing in size for the past 1 year. And then he never seek treatment for the swelling before. The swelling associated with pain for 1 week duration and past discharge for 1 week. Deny any fever and deny any difficulty in breathing. And then he was referred to HRPZ, and he was treated as infected neurofibromatosis of anterior chest wall, underwent excision biopsy of a left anterior chest wall by our colleagues. In trial finding, there was huge mass 8 cm times 8 cm. And then at that time, they never referred to our team. So HPA came back with malignant peripheral nifid tumor high grade, and unfortunately the tumor seen at the surgical margin. Then CT scan show multiple metastasis to the lungs and bones. And then he was referred to ortho due to the MPNST. As you can see here from clinical examination, there is scar on the left anterior chest, multiple cafe outlet spot scenes on the body. And the last case is 61 years old Malay lady underlying neurofibromatosis. It's a referred case from a hospital Kuala Terengganu. She presented with anemic symptom for the past 1 week, associated with swelling at the back of near the lumbar region for 1 year's duration. Swelling increasing in size around thumb size, then it increasing in size since last year, and then swelling become ulcerated last month and associated with on and off bleeding. On examination, there is multiple cutaneous fibromas seen on the whole body, and patient unable to lie flat due to swelling on the back. This is swelling. This is sorry for the limited view on the body because of we don't have the picture before the operation. This is intra-op picture. This is huge mass on the posterior lumbar region on the left side. And then measuring about 15 cm times 50 cm with necrotic central necrotic skin on the soft tissue. She underwent white local excision biopsy, and then however the HPA is still pending. Then thank you. I will pass back to Mr. Munir.
So in conclusion, we need to know MPNST is a rare disease. It does only the incidence rate is only 2 to 3% of all soft tissue sarcoma. Soft tissue sarcoma itself is a rare tumor. However, MPNST is more rare compared to other soft tissue sarcoma. But despite of its rarity, we need to rule out malignant transformation in a patient with neurofibromatosis. Patient of neurofibromatosis presented with big mass, we need to rule out MPNST. So as we've seen in the first two cases, because infected neurofibroma is almost absent. I can't find anything except for the single case report published in 2010. So as we seen in the case presented just now, 2 of the cases actually was treated as a infection, even though patient presented with deep that case number 2 ni we don't have the image lah, because we never see the patient before it was excised. We only see the HPE report, but the first case, you see this size of mass cannot be infection. Okay, anything this size definitely pejam mata, you raba-raba, this is malignant. Okay, so everybody need to at least know a little bit about the basic behind the malignant transformation of any tumor actually. So any tumor more than 5 centimeter, deep-seated, rapidly growing, we need to do a proper assessment and do a proper referral. Because early referral, we must remember early referral may improve survival rate of the patients. The low survival rate may be because of the late presentation, when patient presented always with metastasis. So if we do have early referral, probably we can improve the patient survival rate. Yeah, that's all from us. Anything question?
Thank you, Mr. Ahmad Munir, and the one for very good informative presentation. Now we are open for any question or query from any members of the floor.
Thank you to Mr. Munir for the very informative presentation. So, from your presentation, case presentation just now, something that point out regarding the management flow. So, it seems like orthopedic only received this case at the end, maybe the late stage already. There's other department already managed this patient, do all the surgical procedure, send the HPE, and then came back already at the end. Right? So the question will be, right, for this neurofibromatosis or the subsequent stage, who is supposed to be the department who managed this case initially? Because we don't want to make everybody confused, even at the ED level or even the district level itself, they will confuse to whom they should refer this case, orthopedic or surgery. Definitely surgery, when you want to do this kind of case procedure, right? Okay, so we need to make a stand which department was supposed to be the primary team. So that other places, district, KK, or even our ED also know the main thing who's supposed to manage this patient from A to Z. We don't want to be like, yeah, initially managed by other department, at the end something happened, then pass it to other people. Alright? It can be maybe Dr. Anwar or you yourself can answer it.
So for neurofibromatosis, manage this kind of injuries. Nothing should be orthopedic. Things, but the time, neurofibromatosis and goals.
Okay, thank you, Anas and Dr. Munir, Mr. Munir. The purpose we present this neurofibromatosis, there are a few objectives I have. Number satu, as mentioned, diagnosis is factor. So what our objective is, all of us as a doctor, healthcare provider must know something about neurofibromatosis. Okay, you must know what is neurofibromatosis. And unfortunately, in our country, there is no such thing as follow-up or surveillance of this neurofibromatosis. In the advanced country, they've got a pediatric learning, they are the surveillance. Every year, they follow up. And then adult, they also follow up. Why? Because we are talking only MPNST equate sahaja. They also at risk of develop other tumor deep inside, glioma. Okay, they may also have a develop what you call deep-seated MPNST. But unfortunately, in our country, because we are kita tak ada orang follow up lah. Ada problem datang, tak ada, no people. And second thing is, we also need to highlight to all those patients yang ada neurofibromatosis regarding the counseling part of it. Why? Because it is affected, one parent is affected, it means 50% chance that children akan kena. And the penetration rate 100%. Dia tak ada kata 30%, 40%. Penetration rate means kalau dia ada kata ada separuh saja, separuh presentation tak ada. No. This is the neurofibromatosis. And besides that, kalau you baca literature, neurofibromatosis, kita hanya tengok kulit neurofibroma, kita hanya tengok apa tu capriolis and things like that. Actually, if you read literature, it's also associated with a lot of other conditions. Even mental problem, growth problem, hormonal problem. But unfortunately, our country kita tak ada follow. Don't even have a proper surveillance follow. So this is one of the aspects kita highlight. That kalau kita if we follow an incident quoted is 1 in 3,000. Our population is 32 million. 32 million, ataupun 33 million. I mean, we in our country will have at least 11,000 people with neurofibromatosis. 11,000. 11,000 sikit je kok. Okay. But all of us must have seen the neurofibromatosis. So as a medical healthcare provider, I think we must know what is neurofibromatosis. Okay. And number 2 yang kami nak highlight is that when the growth suddenly so big, to me, you must have conscience, you must be corrected, you must refer early, rather than you treat as infected. Of course, bila dia outbreak, you akan kata infected. Kan, bila dia outbreak, you kata infected. So the awareness must be there when any growth tiba-tiba membesar, any growth tiba-tiba menyebabkan sakit, any growth tiba-tiba menyebabkan symptom, there is an earlier sign you must refer. Okay, rather than wait. So unfortunately, all our patients now is all with the multiple meds already, where you know the prognosis multiple meds is almost 0% chance. Okay. Now, next question is there any medication, anything can be done for the plexiform neurofibroma? I went through the literature. Actually, they start coming out with some medication. They are trying some medication for the plexiform neurofibroma. Why? Because the plexiform neurofibroma is carry the risk of up as high as 15% for malignant transformation. That is why internationally they are trying medication to treat plexiform neurofibroma. There is available, even though the result is not very convincing, but as usual, all these they're gonna try, and then hopefully one day they'll come up with a medication for that. Okay, so this is a development for the neurofibromatosis. So I think all of us kita kena tahu, and we need to know how to counsel that or anybody who has neurofibromatosis. Okay. If the patient see us, normally I will tell them, you have chance, especially plexiform, your risk of malignant transformation is high. Kita tak kata berapa-berapa. Kita hanya kata high, any changes, please come early. Any changes, please come early. Okay. Cuma kena ingat, no? Kalau budak itu masih budak lagi, plexiform can still grow. So jangan excited pula budak kalau dia grow kita kata malignant transformation. No, because plexiform neurofibroma can grow as a child grow. Okay, remember that. So don't agree their child and you say ini malignant. Tapi no, don't take that. Okay, so we can still do the biopsy and things like that for that. So be careful with that. I don't want to have a wrong message kata besar neurofibromatosis. Okay. Neurofibromatosis, there's no management for it. There's no medication because it's a genetic condition. It's a genetic, it's a dominant. Autosomal dominant, you cannot do anything. Kan? Kecuali kita tukar gene kita, which impossible. So that's why overseas advanced country there is surveillance. Every year dia akan tengok budak. Begitu juga adapt sampai dia besar. And orang akan tanya, patient with neurofibromatosis is a life span longer or sama dengan kita yang tak ada neurofibromatosis? The answer is their life is shorter. Their life average from the study, they are about 10 years shorter than kita. Maybe partly because of all this malignant transformation. Okay, so they are shorter. Okay, so tak ada medication, cuma yang saya kata ubat adalah mereka nak cuba control plexiform neurofibroma. Okay, dia nak cuba control. Ya, cuba. Okay, if we can get a clear skin margin, then healing should be fine. However, during the surgery, if you see the surgery sometimes, as if that we cut through the neurofibroma. Faham tak? Kita macam dosing the OT dia sorry lah kan. Masa kami nak buang tumor tu, some of the skin incision we have to go through as if like neurofibroma. Okay, but fortunately so far healing is not an issue. So far we have not seen any problem with the healing process. Okay, lagi. Kalau ni kami buat tu macam peta. Masuk keluar nak elak neurofibroma. So far okay.
So to add on in your mistake, is there any problem of the patient I showed just now, plexiform neurofibroma, we had 4 cases of plexiform neurofibroma with such it is one of the major complications. 2 of the patients stayed in the ward for 1 month just for dressing and care. It just break down. It just has some edema. I mean, secretion from the wound. It's just a wound complication. The patient stayed quite long, and we have to take care of the wound. Very thoroughly. Another patient, slightly smaller. Patient does have some complication, but doesn't require hospital stay. All of the patients at least 1 month to heal.
Probably there's a wound complication. Generally, dia tak ada kata dia is difficult to heal. Okay, lagi any questions?
We did receive a lot of requests by asking regarding so-called cosmetic excision. Do we do that at the
Answer is no. There is no such thing as cosmetic remove of anything. Kecuali saya di private mungkin. Except that when the growth causing a lot of disfigurement, no, ataupun the growth causing problem functionally. We have a few cases plexiform dekat kaki. We have to excise because difficult in shoe. Nak beli kasut, nak pakai kasut. Okay, so kami terpaksa buang. So this is what we call the debulking surgery. Kami buat debulk, buang bulk saja. Tetapi healing masih tak masalah. We cut through the plexiform, but no problem in healing. Okay, any more question? So kosmetik tidak main dalam hospital kita. Siapa nak pergi private dulu? Nanti tunggu saya bertanya. Okay. Post surgical, they will not recur. Okay, they will not recur because all this is just a benign. They tak recur. Okay, apa beza dengan neurofibroma dengan plexiform? Apa beza neurofibroma dengan plexiform? This nodule. Nodule is just from the Schwann cell plus mast cell. Okay, the plexiform dia terlibat dengan a few vesicle of the nerve. Sebab tu dia jadi banyak. A few vesicle. Kalau kita tahu anatomical structures of the nerve, okay, Schwann cell is just a kulit macam balut nerve itu saja. But plexiform is the vesicle, the nerve itself. Okay, so this is a different. Alright.
We have one question from YouTube channel.
Okay.
Dr. Ahmad Razin asked, was all 3 patients started on chemotherapy? What was the final outcome?
The first patient, we have referred to oncology, but still early, first patient. And the truth, just is you by so the outcome is still yet to be seen.
Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Saudi. Actually, in when we start with chemotherapy, usually it has a type of usually the outcome once is before it reaches to stage 3 or stage 4 is that when the involvement of the lung is involved. Its outcome after with chemotherapy is 30 to 45%. And the survival rate after chemotherapy it can increase up to 3 years. Without chemotherapy at the stage of chemotherapy, the survival rate is less than 1 year. That's the outcome of the PTSD with or without chemotherapy. So when we come back to our discussion, what we in neurofibromatosis is benign condition. What we discussed when we referred to the sarcoma, right, this one being told previously, is when it have risk or features of MPNST in a large lesion isolated area with fast growing. So that issue we have to address. Okay, in our country, when we see neurofibromatosis is like previous said previously, is still under macam kita tak ada kesedaran sangat. Actually kita dah ada kita kena buat untuk actually group of neurofibromatosis for the patient. Now we have macam Facebook, kita ada group community, small community in neurofibromatosis, small one Facebook over the 500 followers. Majority of that is of the neurofibromatosis, and then we have to start and initiate the program is from the school, and then we'll reach up to the adult level. So from there we can emphasize kesedaran pada masyarakat tentang neurofibromatosis. Dia adalah benign condition, however risk of malignant perubahan malignant itu ada. So bila ada perubahan malignant, datanglah dapat rawatan segera.
Thank you for all the questions and answers provided. If there is no more question, I would like to invite Dr. Tengku Anas Fadli, Deputy Hospital Director 2, to deliver the certificate of appreciation to our respected today's CME presenter. Please welcome. Dr. Wan Muhammad Amir. Thank you, Doctor. With that, we have come to the end of today's CME session. The upcoming CME will be presented by infectious control team with the topic that will be informed later. Thank you everyone. Assalamualaikum warahmatullahi wabarakatuh.